Welcome back. Today we're continuing our chapter-specific guideline series with a deep dive into infectious disease coding, focusing on MRSA, antibiotic resistance, Zika, and COVID-19. These conditions come with very specific rules, so understanding the guidelines is key to accurate and compliant coding. Before we begin, a quick but important disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. One of the foundational rules in infectious disease coding is to always identify the organism. Some infections are classified outside of Chapter 1, and in those cases, we need to add an organism code from categories B95-B97. We start by coding the primary infection, check for instructional notes, and then assign the appropriate organism code, like B95 for strep or staph, B96 for other bacteria, or B97 for viral agents. When an infection is documented as antibiotic resistant, we need to capture that. If the primary infection code does not already identify resistance, we assign an additional code from Z16, resistance to antimicrobial drugs. The Z16 code always follows the infection code. This helps track resistance patterns and supports public health reporting. When coding an active MRSA infection, the first question is, does a combination code exist? If yes, assign the combination code, such as A41.02 for MRSA sepsis or J15.212 for MRSA pneumonia. And do not add B95.62 or Z16.11. If no combination code exists, then we code the condition first, like a wound infection, and follow it with B95.62 to identify MRSA as the cause. Again, we do not assign Z16.11. MRSA colonization is very different from an active MRSA infection. Colonization means the organism is present but not causing illness. Common documentation phrases include MRSA screen positive or nasal swab positive. For colonization, we use Z22.322 for MRSA carrier, Z22.321 for MSSA carrier. These codes reflect status, not disease. When a patient has both MRSA colonization and an active MRSA infection, we code both. For example, if the patient has MRSA sepsis and a positive MRSA nasal screen, the correct sequence is 1. A41.02 for MRSA sepsis. 2. Z22.322 for MRSA carrier status. This gives a complete clinical picture. The infection explains the admission, and the carrier code reflects the patient's status. For Zika virus, we follow the confirmed cases only rule. This is an exception to the inpatient guideline that normally allows coding of suspected conditions. We only assign a 92.5 when the provider documents a confirmed diagnosis. If the provider uses terms like suspected, possible, or probable, we do not code Zika. Instead, we code symptoms or assign Z20.821 for exposure. COVID-19 follows the same principle. We code only confirmed cases. For a confirmed diagnosis, we assign U07.1, and confirmation requires only the provider's diagnostic statement, not a positive test. If the provider documents suspected, possible, or probable COVID-19, we do not assign U07.1. Instead, we code the signs and symptoms. When COVID-19 meets the definition of principal diagnosis, U07.1 is sequenced first, followed by the appropriate codes for any associated manifestations. Other conditions take sequencing priority only when a specific guideline requires it, such as pregnancy, sepsis, transplant complications, or newborn cases. And don't worry, we'll be reviewing those chapters in future videos as we continue diving deeper into the ICD-10-CM guidelines. When COVID-19 is the principal diagnosis, we add codes for the specific respiratory manifestations. Examples include J12.82 for COVID-19 pneumonia, J20.8 for acute bronchitis, J80 for ARDS, J96.0 for acute respiratory failure. We can also use J22 or J98.8 for nonspecific lower respiratory infections. When COVID-19 is not confirmed, we code based on the encounter type, Z20.822 for exposure, Z11.52 for screening. Symptom codes like R05.1 for cough or R50.9 for fever. If exposure is suspected and symptoms are present, we code both. For patients who have recovered and are seen for follow-up, we assign 1. Z09 for the follow-up encounter. 2. Z86.16 for personal history of COVID-19. For post-COVID conditions, also known as long COVID, we code the specific condition first, followed by *U09.9. This code is only for sequelae, not active infection. MIS has 3 coding pathways depending on the patient's COVID-19 status. Active COVID-19, U07.1 plus M35.81. History of COVID-19, M35.81 plus U09.9. Exposure only, M35.81 plus C20.822. Always sequence based on the clinical scenario. There are a few additional rules to keep in mind. For asymptomatic individuals with a positive test, query the provider. A false positive is possible. For antibody testing, use Z01.84. Vaccination status can be captured with codes like Z28.310 or Z28.311. To wrap up, here are the 3 core principles for infectious disease coding. 1. Always add specificity, organism codes, resistance codes, and secondary details matter. 2. Distinguish status from sickness, colonization is not infection. 3. For modern viruses, trust the provider's word, confirmed cases only for Zika and COVID-19. Thanks for watching, and I'll see you in the next video.